Welcome to Nourish MD, Doctor Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
Hello, everyone, and welcome back to Nourish MDs. I'm one of your hosts, Romana Brennan, joined by Lauren Papanos, as well as our very own Dr. Van Meter. We're so excited to be joined by Dr. Van Meter today, talking all about prostate health. So, Dr. Van Meter, why don't we just jump right in? Can you describe what is the prostate? What do people need to know about the prostate gland and what that entails for overall health?
Yes, I mean, the prostate gland, first of all, today with all the different gender things that we talk about, generally the prostate is in the male reproductive system, and it's a small organ right outside the bladder. It's about the size of a walnut or a ping pong ball, if you wish, and on examination, it is somewhat spongy, and the reason is it's a very muscular little organ. It actually is designed to provide fluid along with the fluid from the seminal vesicles and other glands, as well as the sperm that comes from the testicles. That together makes semen. And then during ejaculation, it is muscular and is able to force out the semen for at least reproductive reasons, okay? So it is really a gland that is designed primarily for the health of the sperm and to help aid them in their transit out, so to speak. It has three major little zones. One is the transition zone, which is an area that is the smallest part of the prostate, about 10% of the volume of the prostate, and it surrounds the urethra, which joins right into the bladder. The urethra comes out of the bladder through the prostate and then on out. That transition zone is very important, particularly in men when they get over 60. That's the part that swells and creates all the problems in men, and that's called BPH, or benign prostatic hyperplasia. Surrounding the transition zone is something called the central zone. Makes up about 20% or so of the prostate gland, and surrounding that and the rest of the gland of about 70% or so is what's called the peripheral zone, and the peripheral zone is generally where most of the prostate cancers come from. So it's a small gland. It's very essential in reproduction and survival of the sperm. And I think most of the time we'll see as men age, it does become a problem.
Why is it that as men get older, it tends to become a problem? Is it something to do with the natural progression of their reproductive system, maybe no longer being utilized for reproduction anymore?
Yeah, that's an interesting question, because generally we would expect probably most men start having problems after the age of 60 generally. I mean, right now we're always concerned about the development of prostatic cancer, but the majority of men will have a problem with that transitional phase, swelling, and having what we call BPH. And it becomes a real issue and a natural phenomenon. I would say that probably most of the men over the age 60 are going to have some kind of urinary tract issue with either hesitancy, frequency, incontinence. All of that is based on that gland enlarging. So it probably is somewhat similar to the way we all age, arthritis, etc. The gland tends to age, and I think that from the age of 13, 14, when the prostate really starts becoming active, that it is active up until the man dies generally. But as its activity goes through all those decades, it probably is, again, an aging process. And for some reason, that particular area of the prostate tends to hypertrophy. And by doing so in that narrow part of the urethra, it causes all the problems that most of the men face, with all the incontinence and problems that they have with BPH.
Got it. And you mentioned BPH. What are some of the other common prostate-related issues or conditions that you see amongst patients?
Yeah, I see that, probably in a younger man, the problems are probably inflammatory. So they usually are prostatitis or infection of the prostate. And that could be acquired for a number of reasons, whether it be sexually transmitted diseases or they have any infection in their system and they have it settled into the prostate. The older the man gets, most of the problems become twofold. One would be the benign hypertrophy or hyperplasia, which is probably prevalent in any of the men over 60, 65. They start seeing signs of that. And it gets worse as the man gets older, generally. And the other is in prostate cancer. I think prostate cancer is a thing that most men will focus on with the prostate. Infections can occur as well when you retain urine and don't empty the bladder totally. And they happen to have a bacterial issue with it, whether it be systemic bacteria or manipulated, whether catheters or STDs. Those bacteria live in the bladder, and then we end up with bladder infections or cystitis. Ultimately, that'll spread up the ureters and sometimes into the kidneys, and then you get nephritis or infections of the kidneys. So it's kind of a domino effect. The prostate is the initial problem. You start having issues with your bladder. You can form, without emptying the bladder stones, bladder infections, polyps, and then ultimately you can have infections that become systemic, and the man many times gets septic. And we see that frequently in nursing homes or men that are dehydrated, never empty the bladder. It gets infected, particularly if they have urinary catheters in. Sepsis becomes a real issue, particularly in men over the age of 75, 80 and are non-active and particularly bedridden. So that becomes a real big issue down the line for men in nursing home settings, etc.
Yeah, thank you for describing kind of that broad spectrum of ways that this can become an issue. Two things that you had mentioned that I wanted to just clarify for anyone who's listening. Can you describe the difference between hypertrophy and hyperplasia?
In a lot of ways, when you read the literature in that, hypertrophy just means a swelling of anything. Hyperplasia means cellular growth in a large bit of cellular numbers, so to speak. I think the two are a lot of times intermingled. We always used to call it benign prostatic hypertrophy, but the hypertrophy is more generalized, just swellings. So hyperplasia is actual describing cellular growth, which encroaches then upon the urethra itself. So technically it would be benign prostatic hyperplasia.
Got it. Thank you so much for clarifying. And I know we were mentioning a little bit more about prostate cancer, but would love to chat a little bit more about that in terms of what populations do you see specifically are at the greatest risk of developing prostate cancer?
Yeah, I mean, over the last number of years, I think right now there's probably estimated, and these are rough estimates, roughly about 1 million men per year are diagnosed with prostate cancer. We lose about around close to 300,000 men die every year from prostate cancer. So it is pretty prevalent. I mean, lung cancer is still, I think, leading the edge, but now that smoking has been declining over the years, the lung cancer statistics are starting to drop. But 300,000 men a year are passing away from prostate cancer. I would say that probably in the lifetime of most men, between 1 out of 8, 1 out of 9 men will get prostate cancer. It is familial. There is a family linkage. There's between a 2 and 3 time greater chance of getting prostate cancer if your immediate male relatives, like a father, grandfather, son, or brother, has prostate cancer. So that increases. Age is generally over the age of 50 and normal. If you have a familial relation that has prostate cancer, we start testing men at least at age 40 and above. So the risk goes up after the age of 40. Probably, I would say 50% of the men that have prostate cancer are generally over the age of 65. And it's based a lot, not necessarily, that's kind of a generalized, but it's based on race as well as weight and smoking history. So those three factors tend to increase the risk for cancers.
And is there a certain gene that can be tested for if a patient has the familial risk factor?
Yes, there are. And I think if we were to get to discuss some of the treatments, or at least the diagnostic, one of the ones is the Exodex. And what that does is it takes, right now we're looking from a genomic standpoint, using extract of exosomal RNA in urine. The three, if you want to call it gene signatures or gene groupings that we look at, would be three genes would be the ERG, the PCA3, and the SPDEF genes, which are the ones that are actually tested and looked for in the Exodex test. So now we are getting into the genetic monitoring, trying to pick up with the use of the Exodex. We're getting about 30% more diagnostic cases as opposed to just using the PSA as a guideline, which PSA has its limits. There's no doubt about it. But that was the first marker that we used. Its sensitivity and specificity is not that great. To answer your question, there are some genetic material that we now look at, and most of this genetic or genomic information is coming from the urine itself, and we use it primarily on the first gathered urine. Usually have a man hold it for at least an hour or so on the bladder, because the first urine that comes out is usually that portion of the urethra, which is lying inside the prostate gland. So it picks up that initial, what we call exosomal molecular test, and that's what we're looking at as far as the labs, what they're looking at as far as the genetic RNA material that put either a high risk or low risk. The goal is basically trying to see whether or not a man poses a low risk or a high risk situation.
And then is that a simple test that any primary care physician runs? Does someone have to see a urologist? Who can run that test, and how might someone go about requesting that kind of information?
Yeah, I think that's a good question. I think that right now that particular urine test is available. Any of the primary care docs, internists, family practitioners. We always tend to go to the urologist, but generally most men are going to, when they start having symptoms that they're worried about, and there are a number of symptoms that we could discuss about what to look for if a man was really concerned that he's having not only a definite problem with the prostate, but if he becomes a little bit more concerned that he might have cancer or something. The primary care docs can certainly run all these tests. So I know the urology groups that we have around our practice, they're very busy, and they're getting busier every year. They probably like it when the patients are screened or looked at first with the primary care. If some numbers look very suspicious, or we're really worried that there might be a possibility of cancer, and that could be based on a combination of exams, that would be the DRE or the digital rectal exam, MRIs of the prostate itself, the Exodex test, the PSA test. All of these are pieces of the puzzle that you can put together and gather that information. And then if it looks very highly suspicious that the man's got a real problem that's more than just benign prostatic hyperplasia, then we would say maybe it's time that the urologist gets involved. And generally that's what they like, and not have to run all that preliminary stuff.
Discover the wellness you deserve. At Private Physicians Medical Associates, PPMA, you'll receive personalized premium preventive care and one-on-one medical attention with an emphasis on prevention, nutrition, and wellness. Extended office visits, appointment availability, 24/7 physician access, limited patient enrollment, PPO insurance and Medicare accepted. This is concierge medicine. This is medicine the way it should be. Call today for a free consultation at 949-566-8888. 8179.
And what are some signs and symptoms before someone gets to even doing the testing that might make you suspicious that that testing is even necessary?
Yeah, that is an interesting group of symptoms that gather themselves, whether you have BPH because the man's aging, or whether or not we're looking at the potential that this might be prostate cancer. A few of the initial things would be anything along the lines of any change in urine flow. So most guys know when they start having a little incontinence, they have a change in that urine flow. They have frequent urination, particularly at night. Getting up a lot of times. You see all the commercials on the airways that how many times you get up at night. That's based on a lot of things, whether how much fluids you take after dinner, things like that. But also the fact that most men after the age of 60, 65 then have a difficulty emptying the bladder totally. So it doesn't take long for the bladder to get full again. And so there's where the frequency comes in. The other thing is pain on urination. A lot of men start developing what we call dysuria or pain when they urinate. And that can or may not be related to actually pain in the prostate. Pain in the prostate is usually men sitting or riding a bicycle or something. They start getting pain in that groin area. That could actually be prostatitis. Could be an infection like we spoke before, but also pain on ejaculation or even having blood in your semen or urine. And then obviously if someone has persistent pain in the lower back or in the pelvic bone structures, the hip, etc., then we start worrying if they don't improve that much as far as the pain in the back and that from what we call arthritis, and they take anti-inflammatories and there's no improvement. Then we get very suspicious that maybe there's something going on in the bone. So when you couple that with all those other signs and symptoms that we see with the urination, and even it may or may not have blood, but then you start getting very suspicious that if he doesn't have at least BPH, that he may have something more serious, and then I think then there's a lot more attention paid to the fact that he may have the beginning of some prostate cancer issues.
And as those symptoms might be coming to the surface, developing slowly over the course of many years, months, are there specific labs or other clinical markers that you recommend individuals monitor even before the PSA, the urinary testing, that type of thing? Are there specific markers that you monitor more preventatively?
Yeah, that's kind of an interesting question, because usually knowing what is going on with any kind of objectivity, most of it is subjective. The patient just tells you their symptoms. They could actually have a normal urine. It's infrequent and it's incontinent and it may or may not have anything in it, blood, bacteria, etc. So we don't really rely a lot on any other particular lab tests other than the urinalysis. I mean, I would think that what we normally do would be a urine on every normal physical. But if he starts having any symptoms, just like we would with a woman that thought she's getting a urinary tract infection or something, most guys a lot of times don't have the same type of symptoms. It could be one of those other signs or symptoms that they have that might say, well, maybe this is something infectious or whatever. So we get a urinalysis. So that would probably be the first thing that we do. Along with that, you might get a blood count like a CDC to see if it's an infection or they have elevated white counts. But short of that, probably the only thing that we really, I wouldn't say rely on, but we tend to use more frequently as a PSA check. It's not always recommended that you have to do that. Certainly the man gets involved with that decision making. One of the things I always ask the guys that are having these symptoms, I say, what are you worried about? And obviously, if the first thing on his mind is, I just worry that I have prostate cancer, well, then we would probably do one of those kind of studies like we talked about with PSA to start with. PSA ranges between 2 and 10. Usually we use the old criteria that anything below 4 is okay. It's not necessarily the absolute number. Sometimes on PSAs, it's the velocity or the change in number over a period of time. So I've had men that we diagnosed with prostate cancer that have PSAs less than 2. And then there are other men that have benign prostatic hyperplasia that have PSAs in the teens, 15, 16, 17, have been multiple biopsies, et cetera, and it's just hyperplasia. So the absolute number, that's why the sensitivity of the PSA and specificity is not that great. Certainly, and it doesn't delineate between a severe grade of prostate cancer or a moderate or a mild type of cancer. Doesn't delineate between the two. It just gives you a number. So having intercourse, riding bicycles, sitting on benches even for long periods of time can rise PSAs. So it's fairly sensitive, but not very specific about anything. But if it does suggest and PSAs rise, then there are the tests like I had mentioned with the Exodex, which is coming out, and there will be probably down the line a lot more different types of genetic testing that will probably be a lot more accurate as far as its ability to at least zone in. I mean, after all, the key thing is trying to catch something in its earlier phase if we can. And I think that it's always the concept of having the right intervention in the right patient at the right time. And I think that when you do that, in particular with some of the new genetic testing, it's really knocked down about 30% already of the basically of cases turned out to be cancer we were not found any other way. So there's not a whole lot of other tests that are really available. And a lot of times the tests aren't even done until the man presents with symptoms. It's a matter of getting men in for their yearly physicals and then just running these things as routine and seeing if even you bring that to their attention. It's, oh, by the way, I've been getting up 5 times every night. They thought every guy does that. Then I think we have to kind of, from a historical standpoint, get deeper into the guy's lifestyle and see maybe he's a high risk.
Yeah. And do any of those recommendations, I know you just said that we don't really test for those things until some of those symptoms present, but for someone who does have a family history, are there earlier preventative or monitoring measures that might be taken starting at a particular age, for example?
Yeah, I think if a man has any of these close relatives that had prostate cancer, number one, we check them a lot earlier. So normally we don't check in, 25-year-old guys or 30-year-old guys. We don't even do PSAs generally. But if they do, then we start doing these kind of studies in their 40s. And a lot of them are already tuned in. If your father, your brother, your son had prostate cancer, most men are a little bit tuned in to saying, I need to find out. It's like colon cancer. If you have a family member, they tend to be patients that are a little bit more receptive to having a colonoscopy. So I think men are the same way, that they've had a close relative that had prostate cancer, and particularly if they pass away from that. They're going to be the ones that will say, hey, can I get my PSA? So we do those at high risk would be at age 40. If he's overweight, there's been an association with weight. Losing weight would be important. Obviously, you can't change your race. Statistics are kind of nebulous at this time, but the African Americans tend to have a little bit higher risk. But the idea is that plus weight control and those guys that smoke. So smoking also, there's an association with a little bit of higher risk. And if you already are at a higher risk from a genetic standpoint in your family members, then if you're overweight, then if you're a smoker, it's probably worthwhile changing your lifestyle accordingly. And that's where you guys kind of come in when we want to start looking about weight control and some of the dietary changes that a lot of these guys need to make. That just lowers their chances. But, I think those studies are still going on to say how much you have to lose, etc. I think it's just a generalized statement that lose weight, stop smoking, and check early.
And are there any other, besides weight loss and maybe cessation of smoking and such, are there any other nutrition or supplement changes and interventions that you've seen to help men with these different types of prostate conditions?
Well, that's actually a good question too. Anything specific I haven't seen. I know that men that exercise, for example, have a lower risk. But if the guy exercises, he's probably going to be losing weight along with it. I know that, and this is kind of still studies that were done years ago, men who use their prostate, in other words, ejaculation of 21 times a month type of thing, have a lower risk of prostate cancer. These statistically have less cases of prostate cancer. Doesn't really mean that that's what you have to do, but the idea is it certainly goes from a biologic standpoint that stands to be a reason, at least another piece of the puzzle that would help decrease your risk factors. So I'm not really aware of any specific nutrient that has been shown to decrease cancer.
Okay. So you're saying that more frequent ejaculation can maybe reduce risk. Is that correct? Yeah. Okay.
It decreases your risk factor.
Yeah. Mm-hmm. Okay. That makes sense intuitively. And we will be sharing some of the different, compounds and nutrients and things and just nutritional strategies in the follow-up episodes of this that'll go live in about 2 weeks. So Romana and I have put together a little bit of like a lit review for you guys on some of those that we've, been able to find some good information on the literature. So that'll be a follow-up if you want to pursue any of those type of kind of more nutritional and supplemental type options. Well, thank you so much, Dr. Van Meter, for all of your insight and wisdom into this conversation. And I think it's really great, some of the information you provided around the different types of prostate conditions and the different ways that we can screen and some of the different like testing and procedures and things that you're doing. So for patients that are currently listening, they're already a PPMA patient, then they probably know where to find you. But for those that may be listening that are not a PPMA patient, can you tell us a little bit more about where they can learn more about becoming a PPMA patient?
PPMA or private physicians, we're accepting all brand new patients. It's concierge practice, and we have a new doctor on our staff. Dr. Davis joined us, and hopefully by January we'll have another new physician that'll join us.
Yes, and we'll be sure to include the website and phone number in the show notes below. And again, thank you so much, Dr. Van Meter. Thank you, Romana, for joining us today. And we will be back for another episode in 2 weeks.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.